Here we are, Dr. St. Louis.
Hi. Thank
Hello,
you.
I'm Jeanice Mitchell.
Nice to meet you finally.
I know, I feel like we know each other already, at least a little bit, but I love the interaction that we get to have here. So thank you so much for carving out time in your busy schedule.
Absolutely. Thank you for inviting me.
Yes. So before we get started, could you share with our audience just a little bit about yourself and where you're located and what you do?
So again, my name's Dr. Sarah St. Louis. I am from Orlando, Florida. I live in Orlando, Florida. I have a solo private practice that I opened about 15 months ago. I see, yeah, it's pretty new. And I am a urogynecologist, so I specialize in female pelvic medicine and reconstructive surgery, and I enjoy teaching and educating women and providing both medical and surgical modalities for prolapse, urinary incontinence, sexual dysfunction, things of that nature.
Yes, all topics that we love to talk about.
Yeah.
Okay, so, all right, so we're going to just jump into our topic today is pessaries and conservative management for pelvic organ prolapse. So can you tell me a little bit about what are some of the most common symptoms that you see with pelvic organ prolapse?
So a lot of times patients present to my office with the concern that they feel like something's dropping, they feel like something's low in the vagina, they feel this pressure or a bulge. Sometimes the first sign that I hear is that a tampon won't stay in place as well as before, and then just general discomfort in the vaginal and pelvic area. But most commonly, they can actually feel or see something that is low in the vagina or even protruding past the opening of the vagina.
Mm-hmm. Okay, so then what are some of the options available? So somebody comes in and they don't want to have surgery.
So I usually always present them with the most conservative options first. And the very first thing that I always talk to my patients about is pelvic floor physical therapy. I know a lot of docs talk about Kegels, but in my opinion, I think, I'm not sure if the statistic is actually that up to a third of women are not performing a Kegel correctly on their own.
Right.
But I feel like, I don't think there's a lot that someone can do by themselves just with Kegels. I think that physical therapy and all that it entails really brings it around and can treat more than just prolapse. So I start them right off with a referral to see a specialist, to see a pelvic floor physical therapist to help with their prolapse. And that can help with that symptom of the pressure and the bulge and things of that nature. So we start with that. Fantastic. And then we talk about wearing a pessary. And after wearing a pessary, sometimes we can talk about the non-surgical quote-unquote vaginal rejuvenation options, or we can talk about the surgical repair.
Okay, so for someone that's never heard of a pessary, tell us what it is.
So a pessary, I like to describe it as a brace for the vagina.
Okay.
I think it's a very simple way to describe it. It is a support that is fitted for a woman, usually made of silicone, and it is placed inside the vagina and holds her prolapse up. I like to describe the same if you have a knee injury and you're going to the gym to exercise, you may want to wear a brace to support your knee because you don't want to have knee surgery. So the same thing goes for the pessary. You want to wear something to support your prolapse so that you're more comfortable as you go about your activities.
Yes. Okay, I'm going to go a little bit off topic here, but I know you're comfortable with these. So tell me a little bit about the range of pessaries. So I know there's different sizes and shapes, and some you keep in longer than others. Can you tell us a little bit about that?
Absolutely. There's several different sizes and shapes. The two most common are the ring with support as well as the Gellhorn. Up to 85% of women can be fitted with one of those two types of pessaries. Okay. We also have the donut, we have the ring without support, we have the cube, we have the inflato ball, but honestly, the two most common are the ring with support and the Gellhorn pessary.
So if they come in and they're interested in a pessary, they'll be able to walk out that day with one in?
Depending on the office. So
okay.
You'll do a fitting, and we have a fit kit, or an office will have just a bunch of pessaries on hand. And we pick the pessary based on the dimensions of the woman's vagina and anatomy and the size. And we will find a pessary that works best for the woman where they don't feel it. We don't want them to even know that it's in place. Once we decide, we also want to make sure it stays in place. So if they cough, if they squat down, if they bend over, yeah, we don't want it to fall out. So we find a good one in the office, and once we find that size, then in my office, since it's a very small office, we'll order the pessary for the patient and bring them back. But in some of the bigger offices, they have a lot of them on hand, and you can actually have them leave the office with that pessary that day.
Okay, so they can urinate with a pessary in.
Absolutely. A lot of times these pessaries will bring the bladder back up to where it's supposed to be, and patients can empty their bladder better than before. We also want to make sure that they don't develop any constipation with the pessary in place. And for the different patients that I see, some want to learn how to manage and remove the pessary on their own, and others are not comfortable with that.
Okay. And what about sexual activity with a pessary in?
So it is possible to have sexual activity, most commonly with the ring that has either the supportive membrane or doesn't have the supportive membrane. But some women find that sexual activity is very comfortable with the pessary as well as their partners, and others do prefer to remove it for sexual intercourse.
Okay, fantastic information. Okay, so what percentage of people would you say ultimately opt for surgery, or they go through the conservative management and they're like, I've had enough, I'm ready for surgery?
I would say in my patient population, it's probably 50-50.
Okay.
Half of women go with conservative options, which even one of the options is observation. Some women have just noticed they have prolapse. They want to know what it is. They want to know, is it dangerous? Will it affect my life? Do I need to do something about it? And a lot of times once you have that conversation and explain it with them and answer their questions, they're fine with just observing their prolapse over time. And so half of some women, well, maybe 10% of women will choose observation. The other 40% will choose a prolapse support like the pessary, or will choose physical therapy. And then the other 50% of patients will choose a surgical procedure.
Okay, good. And so then who might not be appropriate for conservative management?
Most all patients are appropriate for conservative management. It's a lot of times for me, it's up to the patient and their desire for conservative management. Obviously, going to a physical therapist requires some work on their behalf, as well as some homework. And there are some people that may not fit into their lifestyle, or it may not fit into what they see as an option for them. Conservative management is, in my opinion, an option for every person. The only time you really would focus on surgery is if a patient's prolapse is so severe that they're having a lot of urinary retention, and they're developing several recurrent urinary tract infections, that are becoming difficult to treat. Maybe they're becoming resistant to antibiotics.
That bladder's just sagging down. I have all kinds of models.
I love that. Yeah. So sometimes patients that get a lot of UTIs will require surgery because it can eventually help them empty their bladders better. And also with a lot of urinary retention, if that urine is refluxing up to the kidneys, you can develop kidney damage over several years. So those are patients that we may think about surgery for to fix their prolapse.
Okay. And then on the flip side, there may be some that wouldn't be appropriate for surgery.
Absolutely.
Maybe because of age or medical conditions or.
Absolutely, yes.
Okay.
So there are patients where we would prefer conservative management medically. It's definitely more so that situation than the former.
Mm-hmm.
Yeah, absolutely.
Okay, so we talked a little bit about what does a pessary fitting entail. What is the follow-up like for pessary? So somebody gets a pessary, and then how often, what do they need to do at home to care for it? And then how often do they come back to you, and that kind of thing?
So when I first fit a patient with a pessary, I like to bring them back within 1 to 2 weeks, just to make sure they're comfortable, there's no issues with constipation, with bowel movements, has it fallen out, has it displaced and become a little bit lower in the vagina, are they comfortable pushing it back up, putting it in place. So in 1 to 2 weeks, I'll see them, and then after that, I'll let them fly for about 4 to 6 weeks. And then it depends on whether they are removing the pessary at home or not. So for patients that are fine removing the pessary, cleaning it, and putting it back in, they can go a little bit longer without seeing me. Once they become comfortable, they can go 3 to 6 months before they need to be checked. But for those that are not managing at home, oftentimes you can develop a discharge that can be a bit malodorous, and we have to make sure that there's no vaginal infections and that the tissue is still healthy, that no ulcers have developed or abrasions or lacerations. So I have to bring them in more frequently, between every 4 weeks to every 12 weeks, to check on the health of the tissue. So it's different for each patient.
Mm-hmm. So then how do you check on the health of the tissue on, like if you're bringing them in every 4 to 6 weeks?
That's a great question. So I remove the pessary first, and we clean the pessary off. Then I do a speculum exam. I prefer to use a clear plastic speculum because that way I can actually visualize all of the walls. Yeah, so I can see through it, and it has a light attached to the back of it. So I have light all within the entire length of the vagina. So I can see if there's any lesions, any abnormalities, any tissue that looks like it's getting erythematous or red, any tissue that looks like it's not tolerating the pessary well, like there's an ulcer that's developing. So I can see everything. And that's what and then I will irrigate and kind of clean out the vagina and the discharge, and then we'll replace the pessary if everything looks great.
So what can a person expect at home with a pessary? So it's up to them how much they wear it, how long they wear it. If they want to wear it overnight 24/7, they could, or if they want to take it out and just wear it when they exercise, they could?
Absolutely. So I have patients that will leave a pessary in for up to 3 months at a time. That's usually my older patients that maybe have severe forms of arthritis, and it's difficult for them to manage the pessary and put it in and out. And then a lot of my younger patients that are active, sometimes they'll wear the pessary just when they know they need it the most. Some women say when they're on their feet for long periods of time, if you're planning a day walking around Disney or Epcot with your family or the mall, or if you're working a long shift on your feet, or for a lot of my athletes, they will wear it when they're doing a long race or when they're running or when they're training. So some women will put it in just for activities that they know bothers them, and others will wear it continuously. With that being said, I do always recommend removing it at least once a week because it will help with the discharge.
Mm-hmm. And then how do you clean it? Do you have a special cleanser that you recommend?
Nope, mild soap and water.
Okay.
Even mild dish detergent is actually pretty standard for cleaning pessaries.
Do you have a type of person who is most likely to be successful with non-surgical management? So
a very a motivated person.
Yeah, somebody that's compliant.
Absolutely. Someone that is ready to kind of take charge of things, put in work and put in a little bit of effort to be successful, then I think absolutely those are the patients that are best suited for conservative management.
It's not a magic pill.
And I'm sure you see the same in your practice as well.
Absolutely. Like that first visit, we're going over, hey, this is not a magic pill. It's only going to be successful if you're doing things at home. Like if you just come here once a week or every other week or whatever it is, you're not going to see the outcomes and you're not going to achieve your goals. Mm-hmm.
Absolutely. It's almost something you have to build into your normal day-to-day routines, is the way you kind of have to think about it. So.
Exactly. And that's really the case with anything in life. If you want to be good at it, you've got to put some time in.
Absolutely.
Yes. Okay, so how do you define successful management of pelvic organ prolapse, whether it be conservative or surgical?
That's a great question. So for me, the definition, and for a lot of surgeons, is the patient's quality of life, which is a lot of the reason why we make the patients fill out these long questionnaires when they come in, because we want to know how is it affecting you today. And after we've treated you, how do you feel? So if the patient says, I used to not go to the gym anymore because my prolapse is bothering so much, and now they say, I'm back at the gym 4 days a week, that's a success. So we don't always say, our success is defined by anatomical results. Your bladder was at this position and now it's here. It's really how the patient feels, because research shows that everyone's prolapse can be at a different point and patients can feel completely different. Right. So that's how we judge.
You could have a severe prolapse and not really have that many symptoms, or you could have a mild prolapse and be very symptomatic, right?
Absolutely. And we see it all the time. I'm sure you see it a lot. So, so that's how we judge.
What are the top 3 things that you wish every person knew?
I wish every person knew, number one, that when it comes to their pelvic health, there's nothing that they just have to deal with. if there's something that's bothering them, there are professionals such as you and such as me that can help them achieve a better quality of life and existence. So that's number one. The other thing I want people to know is that when it comes to prolapse and urinary incontinence and urogynecological issues, it's not always surgery. We have a lot of options for surgery. And the number three thing I like people to know is we don't all use mesh, and we don't all have to use mesh for everything. So a lot of people are scared, I think, to reach out because they think that's the only option, and it's not the case.
Beautiful. Good. Well, is there anything else? I mean, I've whipped through my questions here. Anything else that you'd like to share or you think that people would be interested to know?
One question that I actually have for you would be working with patients with pessaries. Do you ever find that it's more difficult to perform therapy when they have the pessary in versus removing it?
You know, from a personal standpoint, I really have, in Central Texas where I've been practicing, generally my patients at the point that they're getting a pessary, like we're like, okay, we've done what we can, go back and get a pessary. So rarely am I seeing anyone with a pessary in. And in fact, this is kind of a sad personal, I have pelvic organ prolapse, and at my visit about 2 years ago, I went to my GYN and I asked for a pessary, like, hey, I'd like to be fit for a pessary. And he was like, oh no, those are only for old ladies. Like, so that was like that was devastating from a healthcare professional standpoint, because I'm advocating pessaries, and you have this provider saying, and I should have been at that point more of an advocate even for myself and for the whole for the whole humankind race. Like, no, we can, you know, it doesn't have to be just a certain age range, right? So I think that there is still a stigma in some regions that we're fighting. Like, it's okay to have younger, active people have pessaries. And I have been managing my prolapse for almost 20 years. My son is turning 20 in December without a pessary, and I'm doing great. But I would also just like to try a pessary too. And in fact, my sister lives in Orlando, and I may be making an appointment with you. So in fact, before this interview, I was like, hey, I'm going live at 1 with a urogynecologist from Orlando. Look at you know, so you may be seeing both of us. I don't know.
Okay. Hey, we're here for you. And I 100% agree with you, and I spend a lot of time trying to dispel that myth. Even patients say, oh, I heard that was for old ladies. You know, when your younger patients come in, my grandma had that. And it's like, no, it's for everyone.
Right. So I think we're making waves, but in the bigger cities, I think it's going to be more likely to be maybe not commonplace yet, but more accepted and more easily accessible, versus when you go into the more rural areas, it's still going to be somewhat of a stigma and a fight. So if you're out there and you have pelvic organ prolapse, a pessary is a great option, and you don't have to have a certain age or a certain even level of descent, right? Like if it's
absolutely, you know, it could be minor, or you know, it could be more prominent. And again, I like to consider it a brace. So it is a supportive device to help you feel better. And that's it.
And then what is your take on some of these other options for internal braces? So like a tampon or poison pressa or Contaform, you know, there's other sponges, you know, there's other things out there that we can put inside to support.
Correct. So the ones that I'm most familiar with, there are certain women that will say, hey, when I wear a Super Plus tampon, my symptoms improve. And so that can be very helpful for women. I absolutely love the poison pressa. That's my other go-to kind of for leakage. That's the bladder support that helps support the urethra to stop the leakage when you cough, sneeze, or laugh. And I've got a lot of ladies that will do that when they go to Zumba class or their exercise class. I haven't had as much success with it in my older patients because of dryness, and it's a little uncomfortable to take out. But I love the poison pressa bladder support.
So if you're out there and you haven't seen it, it's available at Target. It's on Amazon. It's kind of like a hollow little tube that you insert with a tampon-like applicator. You insert it into your vaginal canal, and it kind of expands, and it's a space filler, basically.
Absolutely.
Excellent. I love the conversation. So
Thank you.
Let's see. So in terms of getting to you, this is another question. Do people have to have a referral to get to you? Can they come straight to you?
They can come straight to me. It all depends on everyone's insurance plan, which we can help assist them when they call, but they can also call the back of their insurance card and find out if they require a referral to see a specialist, but most patients do not.
Okay. And we're going to have this recorded and put it on YouTube, and we'll put your website link, but can you tell us what your website is?
Yes, it's www.associates.
Yeah, you don't have to spell
it with an S. And then inurogyn.com, which is urogyn.com. And then we're also on Instagram and we're on Facebook, and we're very responsive.
Yes, you are. So thank you so much,
Thanks for
Dr.
having
St.
me.
Louis, right?
Yes.
Okay,
yes.
Thank you for your time, expertise. I look forward to doing more of these, and maybe I'll meet you in person someday.
Absolutely. Thank you so much.
All right, take care, everybody. Thanks for joining. Have a great day. Bye-bye.
Bye-bye.